our perfusion lecture for NERN 110. So just a quick review, I grabbed this from your book. This is the anatomy of the heart. We're going to talk a little bit more about these as we go throughout the lecture, but I did get this from your book in case you wanted to see it. So when we think about the heart really is kind of like an electrical system. I know we've talked about that before. So everything that occurs with the heart, the pumping of the blood, each heartbeat, that all is really caused by this electrical current. So we call this the conducting system of the heart. So when we think about the conducting system of the heart, we have to think about where it starts. So it starts in an area called the SA node, which is the sinoatrial node. Okay, so we think of the SA node as kind of the pacemaker of the heart. So what we see is that these impulses go through the SA node. They're going to travel through our atrial bundles, which you see there in the picture, okay? Then they're going to go to the atrioventricular nodes, our AV nodes, and then they're going to make their way down what we call the bundle of His and the bundle branches. In order for those that activity to get through that area, it's going to travel through what we call the Purkinje fibers, which are located in our ventricles, right and left. So these are all the very important components of our conduction system of the heart. So you guys definitely need to know that for your exam. The SA node, the atrial bundles, the AV node, the bundle of His, the bundle branches, and the Purkinje fibers. More information that I grabbed from your book takes a more detailed look at the inside of the heart, looking at those coronary arteries and veins. So how does our blood flow through our systemic system and our pulmonary circuits in the body? So we have a couple different periods in the cardiac cycle, and this is important for you to understand. So just relating this back to our blood pressure, we always have a systolic number and our diastolic number. So our diastolic number is going to refer to the period of the cardiac cycle, which we call diastole. This is actually happening when our heart is at rest, okay? This is the amount of blood that is going to be returned to our heart by our veins. Then the other part that we have is systole, and this concurs with our systolic blood pressure. So this is the period of contraction. So when our heart is contracting, okay? And this is going to cause the blood to be pumped out of our heart during this cycle. So what are some things that can affect our cardiac rate and our rhythm? So what type of a rhythm we have? Do we have a normal S1, S2, lub-dub, lub-dub, lub-dub? Is it regular? Or do we have any abnormalities? Or is our heartbeat very, very slow? Less than 60 beats per minute, which would be bradycardia, or higher than 100, which would be tachycardia. So one of the first things we definitely always want to think about is drugs. Did we give our patients something that now has adjusted their cardiac rate or their rhythm? So antihistamines, we talked about this last week, is one of those classes of medications that can cause issues. For example, so pseudoephedrine, we talked about this with our respiratory slides. Pseudoephedrine is going to be responsible for constricting our blood vessels in the nose and the sinuses, right? So that it leads to, it shrinks the swelling and helps drain the fluid, which is great. We love this. It helps us to breathe easier, but it is constricting blood vessels, and it doesn't know to just do that in the nose, so it does it everywhere. So now we're constricting our blood vessels, and we're having an increase in our blood pressure, our actual, circulating blood volume. Acidosis can cause this, which is a condition that our patients can develop when we don't have homeostasis. You'll talk more about that next semester. Definitely decreased oxygen levels, okay? So if we don't have good oxygen in the body, then the heart is going to say, uh-oh, we're not getting enough oxygen. I have to beat faster and harder to get more out. We did talk about some of our electrolytes. Anytime our electrolytes change, particularly our potassium, magnesium, we can see issues with the heart. And then if we are having a buildup of waste products in our body, a good example of this is our kidney function. If our kidneys are not functioning, then this can also affect our heart rate. So, what are some of the arrhythmias that our patients could develop? So, thinking of just our arrhythmias, we can have sinus arrhythmias, we can have supraventricular arrhythmias, atrioventricular blocks, and ventricular arrhythmias. Then our supraventricular arrhythmias would be our PACs, which are our premature atrial contractions, our PATs, which are our paroxysmal atrial tach, aflutter, and AFib. So another thing that you guys really need to understand, especially for your exam, and then you're getting ready to give medications next semester, so you need to understand what's going on in the body, okay, with certain medications that we give and when patients are having issues, what the body's doing. So this I grabbed from your book, but I do want to go and explain this for a minute. This basically is going to be our renin-angiotensin system. So this system is going to try and fix our body when we don't have enough blood flow. So maybe we're bleeding, or we have low blood pressure, or we're dehydrated, or if we don't have enough oxygen for some reason, maybe we're having some type of a respiratory disorder, okay? What's going to happen is that when we don't get enough blood flow or oxygen to the kidneys, we have these little things in our kidneys called nephrons, okay? They are going to become quickly aware that they are not getting the blood that they need. So what are they going to do? They're going to do two things. They are going to release something called renin, okay? That's going to go on to do a couple different things that we're going to talk about in a minute. The other thing it's going to do is it's going to release erythropoietin, okay? If the kidneys can release erythropoietin, then the body can increase the amount of red blood cells going in the body. So we know if we have more red blood cells, we can get more blood to where we can use it, right, to perfuse our organs. And if it's an oxygenation issue, we know our red blood cells are responsible for carrying oxygen. So we are going to increase the oxygen that we have. So you need to understand what the name of the system is, renin-angiotensin system. And you need to understand that it does two things. The first thing we just talked about, it increases our red blood cell production. The second thing it does is the nephrons are going to secrete renin. Okay, renin is then going to go out through the body, and it's going to activate something in our body called angiotensinogen. When it activates angiotensinogen, it's going to then turn into angiotensin 1. Okay, angiotensin 1 is then going to go directly to the lungs. Inside the lungs, we are going to see that angiotensin 1 is then going to be turned into angiotensin 2. Now, two things will happen when we turn into angiotensin 2. The first thing that's going to happen is that we are going to see this vasoconstriction occur inside the body, because right now we don't have enough blood flow. So if we make the area smaller, thinking about that blood going through our body, thinking about vasodilation, we have this big area in our vessels, but a little bit of blood. So if we close that area down and we make it smaller, it's going to make the body seem like we have more blood, okay? So it's going to vasoconstrict everything, and then this is going to increase our blood pressure and increase the blood flow to the kidneys. The second thing it's going to do is that angiotensin 2 is going to go into the adrenal gland, where it's going to turn into angiotensin 3. When it turns into angiotensin 3, the body's going to release something called aldosterone, okay? Aldosterone is then going to cause our body to hold on to sodium, okay? If we hold on to sodium, we know that wherever sodium is in the body, water is going to follow. So it's going to cause us to hold on to sodium and water. If we hold on to water, it's going to build up our circulating blood volume, Okay, so it's going to increase our blood volume, it's going to increase our blood pressure, and it is going to increase the blood flow to the kidneys to perfuse our organs and give us more oxygen. So angiotensin, this renin-angiotensin system does three things. It's going to vasoconstrict to increase our blood pressure. It's going to make more red blood cells, and it's going to cause the body to retain sodium with water to increase the blood pressure. You guys have to understand this system for your exam. And this is the basis for all of your future things that you're doing, especially next semester, thinking about homeostasis. So this slide here is just a little bit of a breakdown of what we just said. So this system is activated when we don't have good blood flow to the kidneys. Okay, renin is going to be released. It's going to go and be converted in the liver to angiotensin 1. It's going to go to the lungs. When it gets there, it's going to turn into angiotensin 2. Angiotensin 2 is then going to cause vasoconstriction. It's going to increase that blood pressure. Okay, it also causes the release of aldosterone from the adrenal cortex. Tells your body, hey, hold on to sodium, hey, which is going to cause us to hold on to water and increase our blood pressure. All right, so now we're going to talk about some medications that affect our blood pressure. So I want you guys to understand why we would give medications to patients that for blood pressure control, mainly because what we see is a lot of patients have hypertension. So you need to know what the different categories are of hypertension. So what do we consider normal? Normal is a systolic blood pressure less than 20 and a diastolic blood pressure less than 80, okay? Elevated is going to be a systolic blood pressure between 120 to 129 and a diastolic blood pressure less than 80. How do we categorize hypertension? Well, hypertension usually comes in two stages, stage 1 and stage 2. Stage 1 is going to be a systolic blood pressure between 130 to 139 and a diastolic blood pressure between 80 and 89. When we get into stage 2, we now see that this is going to be a systolic blood pressure equal or greater than 140 or a diastolic blood pressure equal to or greater than 90. And you definitely need to know these ranges for your exam. So what are some of these common medications that we give for blood pressure control? And you guys do need to know these for your exam. So sometimes we will just start out with a diuretic, okay? Hydrochlorothiazide or HCTZ is what we refer to it as in the hospital. These are diuretics. So what diuretics do is they cause us to be able to pee, okay? If we pee, we're pulling out a lot of fluid and sodium, which means that we're decreasing our blood pressure, okay? We're getting rid of sodium. Sodium causes water to follow. Remember, water and is always attracted to sodium. We have our beta blockers. I always remember our beta blockers because the last three letters of these medications are LOL. And I always think to myself, beta blockers make me laugh out loud. So when I see a medication that ends in LOL, I know it is a beta blocker. We have our ARBs. Our ARBs are our angiotensin 2 receptor blockers. This is going to be your candesartan, your losartan, your olmesartan, your valsartan. So these end in sartan. We have our ACE inhibitors. These are our angiotensin converting enzymes, lisinopril and captopril. We have our calcium channel blockers. We have diltiazem, nifedipine, verapamil, and amlodipine. Unfortunately, none of those have the same letters, so you just kind of have to remember what they are. So we're going to talk about our angiotensin 2 receptor blockers, our ARBs. So losartan in particular, this is a medication that blocks that vasoconstriction and that release of aldosterone, okay? So we just talked about that system. We talked about that vasoconstriction. How does it happen? We talked about the body releasing aldosterone, right? Which tells the system to hold on to sodium and to water. So if we block that system, then the body's not going to hold on to sodium. It's not going to hold on to water. It's going to vasodilate instead, and it's going to decrease the blood pressure, okay? So it blocks the increasing effects of that renin-angiotensin system that we just talked about. So Most of these are given PO, okay? Contraindications. We have to be careful, obviously, because we're thinking about that angiotensin system. This works on our kidneys. So if we have kidney issues, liver issues, we just have to be careful. Side effects. Any side effect mainly that you want to think of is going to be the side effects that you would see of low blood pressure, because we know if we're giving a medication to treat low blood pressure, we can cause if we're giving a medication to treat high blood pressure, we can cause the blood pressure to drop too low. So what are those side effects? Headaches, dizziness, syncope, passing out, weakness, okay? Hypotension, and then sometimes a fever in these patients, okay? You might have some GI complaints as well. They may get symptoms of a respiratory, upper respiratory tract infection. So a cough, a rash, dry skin, okay? We don't want to combine, we just have to be careful, rather, combining these medications that also have antihypertensive effects. And we see this happens all the time, okay? Because patients take multiple medications to try and control their blood pressure. We can see a decrease in the effectiveness of this medication if we pair it with some of our antifungals, and then another type of a medication that we would give for heart rate and blood pressure, which is diltiazem. Our beta blockers, these are our medications that end in LOL. How do these work? These work by decreasing the heart rate and the contractility. So these are going to work on our heart rate, where the other medicines we just talked about worked on that angiotensin system, right? So these will lead to a decrease in patients developing arrhythmias. They will decrease the workload of the heart and decrease basically how hard the heart is working and the oxygen that it's consuming, okay? We have to be very, very careful with our patients who suffer from diseases that cause bronchospasms, okay? So your COPDs, emphysema, acute asthma, because these medications can worsen the blocking system of that vasodilation. So these are not really medications we're going to give to people who have issues with bronchospasms. Guys need to know that. We can also see a decreased antihypertensive effect when we combine them with NSAIDs. So your anti-inflammatory medications, Motrin, ibuprofen, okay? When these drugs are given with insulin and other anti-diabetic agents, there is a potential for a change in blood glucose levels, okay? So we're worried about the patient not displaying the usual signs and symptoms that they would see of that low blood sugar. Our calcium channel blockers, this is going to be our diltiazem, nifedipine, verapamil, or amlodipine. These medications work by relaxing the muscle contraction of the heart. They decrease blood pressure, they decrease the workload of the heart, and they improve the amount of oxygen consumption, okay? How does it work? It inhibits the movement of calcium ions across our membranes, okay, in our cardiac muscle cells. What this does is it causes a depression of that impulse that is going to slow the conduction of the heart. It's going to decrease how hard it's contracting, okay? It's going to dilate the arteries, and it's going to lower the blood pressure and decrease our myocardial oxygen. Just want to monitor your kidney and liver enzymes. Contraindications, obviously, if they have an allergy, some of these medications can make other issues within the heart worse, like heart blocks. So we might have to be careful with them. Again, we're lowering the blood pressure. So we're really worried about those symptoms that we would see related to that decrease of cardiac output. Definitely some GI symptoms as well. Amlodipine is famous for causing peripheral edema. So if this does occur in your patients, then that would be a reason for us to stop giving that medication. We have to be very careful with another medication called cyclosporine, because it can increase the serum levels in the body and become toxic if we take this medication with diltiazem. Our ACE inhibitors are going to work by blocking the conversion of angiotensin 1 to angiotensin 2. So we talked about that in depth at the beginning of these slides, right? So now you know where this medication is working. It's preventing angiotensin 1 from turning into angiotensin 2. So it's not going to vasoconstrict. So we will see also a decrease in aldosterone production. Okay, and a small increase in our serum potassium levels. So we do have to be careful. We would give this medication definitely for hypertension. We definitely give these medications for congestive heart failure. Okay, very popular class of medications that we like to use for heart failure. We would not give if we have an allergy, have to be very careful with renal function. This is something that we will continuously monitor in these patients. So these medications are usually good. They're very helpful, but eventually, because of if these patients aren't controlling their blood pressure, we know that they're going to have kidney issues. So once the kidney starts having issues, we can't use this class of medication anymore. We do have to be careful. We do give it for CHF, but we do have to be careful because we are, remember, moving salt and water, and that could cause an exacerbation, could cause them to become dehydrated. So adverse reactions, again, anything reduced, oh my goodness, I can't talk, anything related to that change in cardiac output that we're going to see. Sometimes these patients can develop a non-productive cough. If they develop a non-productive cough, we are going to stop giving this medication, okay? Our vasodilators, this is another type of medications that we can give. Our diazoxide, our hydralazine, our minoxidil, and our nitroprusside, NitroPress. These are all medications that you will see given that are called vasodilators. So these work on that smooth muscle of the heart to cause muscle relaxation. If we relax the muscle, it causes everything to open up. We vasodilate, and then we decrease our blood pressure. Okay, these are a class of medications that we usually add on to other ones if we're not getting the results that we need. We have to be very careful with people who have peripheral vascular disease and CHF. Okay, we just have to monitor their reactions with this medication. Again, any medication that changes our cardiac output, we're going to be looking for those reactions to low blood pressure. What would we see? Okay, we are definitely worried about blood pressure with these patients, possible headaches, chest pain, edema. All right, so we are going to talk a little bit about congestive heart failure. So congestive heart failure is when the body, the heart, does not pump effectively to get the blood throughout the body. So you can have left-sided heart failure or you can have right-sided heart failure. The primary treatment here is to allow the heart muscle to contract more efficiently so that we can, with each pump of the heart, get out enough blood to perfuse all the organs. So we want to make this heart work better. So what causes congestive heart failure? A lot of different things. If we think about a patient that has long-standing high blood pressure, that heart is always trying to pump into an area of the vessels that has a high pressure. So it's working in overtime. So the heart is a muscle. So it's like going to the gym every day and working out your leg muscles. If you do this every day for 20 years, you're going to have really big muscles because the heart is a muscle. So it's the same thing. The heart gets bigger, but as it gets bigger, it becomes less efficient. It's not as elastic anymore, and it can't get that good contractility that we need to get out the amount of blood that we need. So we call that cardiomegaly. Sometimes we just develop some diseases in our valves. That can cause an issue. Definitely, like I said, this long-standing hypertension. And then sometimes we can develop some coronary artery disease where we get blockages and plaques and stuff like that inside the heart. So what are symptoms of congestive heart failure? You guys will need to be familiar with some of the side effects that you would see from congestive heart failure, okay? So left-sided, think of the blood backing up into the lungs. So we're going to see a lot of adventitious lung sounds, Okay, anxiety, difficulty breathing, not being able to lay flat, maybe coughing up blood, tachycardia, increased breathing. You might hear an extra heart sound. Okay, that's going to be that S3, that extra heart sound because of all the fluid. Definitely GI upset. And then we are going to see decreased peripheral pulses because we are not getting that blood flow out of the heart. Right-sided heart failure, that blood is not getting back to the heart to be able to exchange carbon dioxide and oxygen. So we can think of that blood as kind of pulling on the right side of the body. So we might see pitting edema in our patients, weakness and fatigue. We're not getting good, kidney perfusion. We're going to have our spleen and our liver that is going to, increase in size because of all that fluid. We're going to see ascites develop in the belly because of the fluid. And then we would have JVD with these patients as well. All right, so what do we do to treat congestive heart failure? So you guys need to know this. We would give vasodilators. We talked about these, some of our ACE inhibitors and our nitrates. They're going to work by decreasing the workload of the heart and that overworked cardiac muscle. We can give diuretics. They decrease our blood volume, which decreases our venous return and then decreases our blood pressure. We can give our beta adrenergic agonists. Okay, these are going to affect the amount of calcium coming into our myocardial cells, which are going to cause the heart to contract better, okay, more effectively. We have some cardiotonic medications that we give that cause the heart to basically contract better, okay? That medication that we give is dopamine, okay? So we do give this a lot for heart failure, but this medication can also cause arrhythmias, so we have to be very careful with it. And then some of our cardiac glycosides will also work to increase our myocardial contraction. So we have some medications that are considered cardiotonic. We have two types of cardiotonic. We have our cardiac glycosides and our phosphodiesterase inhibitors. Our cardiac glycosides that we give are digoxin or lanoxin. Digoxin is a very popular medication, been around for a very long time, works very well, so we give this a lot. Our imiodarone or our milorone are also very popular phosphodiesterase inhibitors that we give. You guys should know these as well. So digoxin, you should know everything about digoxin. So digoxin works to increase the force at which the heart is contracting, okay? We know this is going to cause an increased cardiac output and good perfusion to the kidneys, which will have a diuretic effect. It's going to increase our urine output, and it's going to decrease our blood volume because we're getting rid of sodium and water. And it also decreases the renin release and the activation of that renin-angiotensin-aldosterone system. So we're not going to get that vasoconstriction. We're going to see that these patients have a slow heart rate, which is going to then also cause a decreased conduction velocity through that AV node. So basically, these patients are going to have a decreased heart rate and the heart's going to work better. So one of the things that you guys need to understand that you will absolutely always monitor in these patients every time you give it is heart rate. So in order to give this medication, the patient's heart rate has to be 60 or above. We know a normal heart rate is 60 to 100. If it's 55, we know this medication is going to decrease the heart rate. We would not want to bring that heart rate down any lower. So we have got to make sure that we are counting this heart rate for an entire minute. This is a medication where we wouldn't just use the machine. We would actually listen and feel and get this heart rate manually for 1 minute, and we would want to make sure it is 60 and above. So what does digoxin do? It increases the amount of calcium into the cells, brings more into our myocardial cells to increase cardiac output. So we could give this for heart failure, AFib, flutter, and some paroxysmal tachycardia, okay? We would not give if they have allergies or VTAC or VFib, any type of a sinus block or any type of an electrolyte abnormality, because electrolyte abnormalities can cause this patient to develop digtox. Okay, so we really worry about this happens to our older adults because they get dehydrated, their electrolytes get wonky, their potassium, and when this happens, then they're at a higher risk for developing digtox. Okay, so you definitely need to know these adverse effects: headache, weakness, drowsiness, vision changes, vomiting, arrhythmias, digtox. Okay. We do have an antidote that we can give. It's called digoxin immune fab. This is a medication that we can give if their levels become too high. And you guys have to remember, you're counting an apical pulse for 1 minute. And before administering this drug, that heart rate has to be 60 beats per minute or greater. All right, our phosphodiesterase inhibitors. These are going to be our second class of medication drugs that are considered cardiotonic. That's our inoterone and our millerone. These are going to be approved for patients that have heart failure that has not responded to digoxin. So this is not going to be our first class of medications, okay? All right, so how do they work? They block an enzyme called phosphodiesterase, which leads to an increase in our myocardial cell cyclic adenosine, which then is going to increase calcium levels in the cell, which we know now is going to cause a stronger contraction, and it's going to relax that smooth muscle. So it's short-term treatment for patients in heart failure that are unresponsive to other things. You would not want to give if they obviously have an allergy, any type of fluid deficit, or if they've had a heart attack in the past. So what are those side effects? Arrhythmias, low blood pressure, fever, chest pain. All right, now we're going to talk about our antiarrhythmic agents. So different types of cardiac arrhythmias that you need to understand. So tachycardia, we know that's a high heart rate greater than 100. Bradycardia, slow heart rate, less than 100. Patients can develop PACs, premature atrial contractions. This is caused by some type of ectopic focus in the atria that is stimulating an abnormal atrial response, okay? Our premature ventricular contractions, our PVCs, are also going to be that ectopic focus in the ventricles that stimulates an early contraction. A flutter is a single ectopic focus that is generating a fast, regular atrial depolarization. A fib, many ectopic foci firing in an uncoordinated manner throughout the atria. VFib, the ventricles are not able to contract in a coordinated manner, which means no blood is being pumped into the body or the brain. So we know that this is a life-threatening arrhythmia. So what do we do to treat different arrhythmias? A couple different things. Adenosine is a medication that we give to convert people who are suffering from supraventricular tachycardia, so those high heart rates above 150 that they're sustaining. What we'd like to do first, if someone's having this SVT, we like to just tell them to vagal down, practice that vagal maneuver. So that vagal maneuver is basically just simulated by making that motion with your body that you're having a bowel movement and bear down. Sometimes that's enough to just stop the heart, not really stop it, but just kind of keep it from beating so fast. If that doesn't work, then we have to give them adenosine, which is an IV push medication. We give this medication when the patient has the doctor in the room and is hooked up to an EKG. And what this medication does is it temporarily stops your heart and causes it to restart again, hopefully at a normal rhythm. So a lot of education that comes along with this, because we need to educate the patient and let them know that they're going to experience a pretty weird feeling because their heart's going to stop for a second. Digoxin, again, we talked about this, slows the calcium from leaving the cells, which slows the conduction rate and our heart rate. And then atropine is a medication that we give. Atropine actually competes with acetylcholine for those cholinergic receptor sites in the body. It blocks acetylcholine and it speeds up the rate of the heart. Okay, so at different doses, it prohibits that vagal cardiac slowing or asystole. All right, some of our anti-anginal agents. So, angina, chest pain. Okay, that's our nursing medical word for chest pain, angina. So, a lot of patients that have coronary artery disease develop angina and experience angina. So if you look at this picture right here, we have our arteries. Inside of our arteries should be this nice wide open area for all of our blood to be able to travel through without any issues. Being overweight, being sedentary, genetic predispositions, not having a good diet, all of these things can cause a variety of different things to happen in our arteries, which then impairs the amount of blood flow that we get throughout the body. So patients can develop fatty tumors inside the heart vessels. We call them atheromas. Patients can develop atherosclerosis, which is where the vessels become narrow and the pressure increases and we can't get the blood flow through as easily as we used to. Angina pectoris is suffocation of the chest, but that is your chest pain angina. And patients can also develop a myocardial infarction, which is where the cells of the myocardium, the heart, become neurotic and they die because they're not getting blood flow anymore. So, a couple different types of anginas that you do need to know. Stable angina causes no damage to the heart. Okay, basic reflexes surrounding the pain are going to restore that blood flow. So there's no interruption in blood flow. Unstable angina is this consistent, or this intermittent pain that is now causing ischemia at the heart, even when the patients aren't doing anything. So at rest, when they're not doing anything, and they're having this very, very bad, chest pain that won't go away, this is considered unstable angina. Prinzmetal's angina is caused by just this overactive spasm of our blood vessels. So it's not just that the vessels are narrowed, they're actually spasming and we're not getting enough blood around. So we would give anti-anginal drugs, like we said. How do they work? Well, they're going to improve the blood delivery to the heart and they're going to dilate those blood vessels. Okay. When we do that, we're going to increase the supply of oxygen. It just makes sense because we're getting more blood. We're going to improve how well that blood gets to the heart muscle by decreasing how hard it has to work. And then it's going to decrease the demand for oxygen as well. You guys need to understand, especially, the actions here of these anti-anginal drugs. So what types can we give? We can give calcium channel blockers, beta adrenergic blockers, and nitrates. So those beta blockers are going to block that beta adrenergic receptor in the heart and the kidneys. It's going to decrease the influence that it has on that central nervous system, which decreases the cardiac output and the release of renin. We would give this for stable angina, hypertension, and it also prevents a reinfarction in patients that have had a myocardial infarction before. So if they've had a myocardial infarction, a heart attack, we might start them on this medicine to prevent another one from happening, okay? Contraindications. If you already have bradycardia, we don't want to cause it to go any lower, so we're not going to give it. If you have a heart block, if you have asthma, COPD, because of that bronchoconstriction, we do not want to give these medications. We have to be very careful in our patients that have diabetes. Remember, we talked about this before. It decreases the effectiveness of that med and the patient not being able to really understand that their blood sugar is low. They're not going to get the symptoms that they normally would get. We're also going to be looking for anything that is going to block our sympathetic nervous system. So we know what our sympathetic nervous system does. We just talked about this 2 weeks ago. So if we block that system, you guys know what to expect. Any change related to our central nervous system, lowering that blood pressure. So dizziness, fatigue, nausea, vomiting, decreased cardiac output, the potential of arrhythmias, okay? Respiratory, it's going to cause bronchospasm. This is a problem for someone who has emphysema, COPD, bronchitis, asthma, did I say asthma? It's going to cause them to have difficulty breathing, so we do not want to give it. Our nitrates work directly on the smooth muscle of the heart, causes them to relax and depresses the muscle tone. Again, prevention and treatment of attacks of angina. We have to be careful with patients that have had any type of cerebral hemorrhage because we don't want to thin the blood out. Careful with patients that already have low blood pressure, and hypovolemia, so low fluid volume inside the body, okay, because that's going to affect our cardiac output. Adverse effects are going to be related to vasodilating and decreasing our blood flow. So dizziness, headache, weakness, nausea, vomiting, hypotension, flushing, okay, increased perspiration. And then drug-to-drug interactions, we would be careful if we were giving heparin because it would decrease the therapeutic effects. All right, so what are our routes for nitroglycerin? You guys need to know this. IV, we can give every 1 to 2 minutes. Sublingual, 1 to 3 minutes. Translingual spray every 2 minutes. Transmucosal tablets, 1 to 2 minutes. Oral sustained release tablets, 20 to 45 minutes. Topical ointment, 30 to 60 minutes. And transdermal, 30 to 60. Sorry, when I was reading this, I was saying the wrong thing. This is how long it takes for the medication to work at these routes. But how often can you give these medications? Well, usually they can take, multiple doses of these. But what we tell patients is, usually it's every 5 minutes you can take a tablet. So if you have chest pain and you take one tablet, it doesn't work. 5 minutes later, you take another tablet and it doesn't work. When you're getting to take that third tablet, we want to educate our patients that they should probably be calling an ambulance or making sure they're on the way to the hospital, because we would expect that after 2 doses, these medications are helping. So at this point, we're worried about them having some type of cardiovascular event, maybe another heart attack, and these medications are not working. So that's typically what we say. All right, now we're going to talk about different lipid-lowering agents. So lipid-lowering agents will lower our levels of cholesterol and lipids in the body, and they can prevent coronary artery disease in people who are at risk for developing it. So we know some people genetically just have high cholesterol levels, but also high cholesterol levels can develop from sedentary activity, not eating, not exercising, okay? There are some risk factors for coronary artery disease. You guys need to know these. We have some unmodifiable risks, which are things that we are not able to change. And then we have modifiable risks, which are things that we can change. So our unmodifiable risks, things we cannot change, are going to be obviously our age, gender, and our genetic predisposition. Can't change those. Modifiable risks, the development of gout, okay, cigarette smoking, sedentary activity, high stress levels, hypertension, being overweight, diabetes, having bacterial infections that are untreated, and taking tetracycline for long periods of time can cause this as well. So what causes hyperlipidemia? Hyperlipidemia is our word for elevated cholesterol, okay? Basically an excessive dietary intake of fats. Okay, some of our genetic alterations will change how our body metabolizes our fat that can cause elevated fats in the blood, okay, which then causes hyperlipidemia, hypercholesterolemia, hypertriglyceridemia, okay? So you guys need to know this for your exam. What are our lipid blood levels? So ideally, so we're going to look at a couple things. We're going to look at our overall total cholesterol level. Overall total cholesterol, we want this to be less than 200, okay? We're also going to look at our LDL. Our LDL is our really bad cholesterol. We want this to be as low as possible. Less than 100 is ideal, okay? That's what we're striving for, less than 100. our high density lipoproteins, our HDL, this is our good cholesterol. We want more of this, okay? We want this to be greater than or equal to 60. Anything less than that tells us it's not good. How can we increase our HDL? One of the main ways we can do this is by exercise. Okay. Then we also want to look at our triglycerides. Our triglycerides, we always want to be less than 50. So know what your LDL, HDL, and triglycerides are, and know what those levels are that we want for our patients. And you should also know how to bring up that high density lipoprotein, the HDL. So what kind of medications do we use to treat hyperlipidemia? We use some fibrates. We use a medication called niacin. We have some cholesterol absorption inhibitors. We have some bile acid sequestrants and some HMG-CoA inhibitors, our most popular class of medications. These all work a little bit differently. So you should know the different categories and you should know what they're going to affect in the body. So our bile acid sequestrants, these are going to bind to bile acid in the intestine and allow it to be excreted in the feces instead of reabsorbing it, okay? It causes our cholesterol, which is, made in the liver, to become iodized, and then it decreases our cholesterol levels. So we would give this medication for patients who have elevated cholesterol levels. Adverse effects: headache, fatigue, drowsiness, GI irritation, nausea, constipation, longer than normal bleeding times, and then it can lead to vitamin A and E deficiencies. Our HMG-CoA inhibitors, very popular class of medication. These inhibit something called HMG-CoA, which it will decrease our cholesterol levels, our LDL, and our triglycerides, and it works to increase our HDL. This is great. We want things that are going to increase that good cholesterol. Not all medications will do that. So, of course, the other thing you guys need to understand that with like any other medication, these should be given in conjunction with healthy diet and exercise. Okay, we shouldn't just say, well, I'm going to take this medication every day and still continue to eat red meat and really high fat stuff. Okay. So we want to make changes to our diet, increase our exercise, and then use this as an aid to decreasing our cholesterol. Let's see. They also can mess with our endocrine function, so we have to be very careful. All right, adverse side effects of these. You guys absolutely need to know these and the drug interactions. So GI side effects, lots of gas, belly pain, cramps, maybe some nausea, vomiting, and constipation. Definitely effects on our central nervous system, headache, dizziness, blurred vision, insomnia, fatigue. We are worried about liver failure. Remember, cholesterol is made in the liver. These medications work in the liver. So we are checking liver function, LFTs, before we give this medication and throughout the course of treatment as well to make sure that the liver is still working appropriately. There is a side effect that patients can develop called rhabdomyolysis. If patients develop rhabdomyolysis, this is a reason to stop taking this medication. If these patients stop taking this medication, it's probably because they developed this. So rhabdomyolysis is where the body starts to burn protein instead of fat, and it causes severe body aches in the body, okay? Severe muscle aches, brown urine, and it can shut down your kidneys. So what do you think is an assessment that we would want to do before we start these patients on this medication? We said we're going to look at LFTs, but we also want to assess, do they have any pain at baseline? Because what if they come to us after taking it for 4 weeks and say, I'm having body aches? Well, did you have body aches before you started this? We need to know, are you having any muscle aches? Okay. We also want to look at kidney function. Okay. We have to be very, very careful. Grapefruit juice decreases the effectiveness of this medication. and it can cause toxicity of taking with warfarin and digoxin. We have our cholesterol absorption inhibitors. These work in the small intestine to inhibit the absorption of cholesterol. Okay. Do not take if you've had any reaction to these medicines. And if you're pregnant, you cannot combine these with another statin. They can only be taken by themselves. Adverse effects: muscle aches and pains, abdominal pain, headache, dizziness, fatigue. This is the site of action where these medications work. Some other medications that we give: niacin, fenofibrates, and gemfibrozil. You guys need to know this. Niacin, vitamin B3, is going to inhibit the release of free fatty acids from our fat cells. It's going to increase the amount of nitroglycerides that we can remove from our serum, lower our levels. Fenofibrates inhibit triglyceride synthesis in the liver, going to decrease our LDL. Then it's also going to increase the amount of uric acid that we secrete, which stimulates our triglycerides to break down. Gemfibrozil is going to inhibit the peripheral breakdown of lipids, and it's going to reduce the production of triglycerides and LDL, and this medication also increases the HDL. So you will see that not every medication works to increase our HDL. All right, now we're going to talk about drugs that affect how our blood coagulates. Several questions on your exam about this, so you need to really have an understanding of how these medications differ and work. So, brief overview. We talked about this in the beginning of the semester. When we think about how does our blood coagulate? Well, it's a very detailed process. Basically, we get this injury somewhere in our blood vessel. The body's going to do a couple different things to try and fix this situation because we don't want to bleed out, right? So we can't just have one system. We need to have 4 ways to be able to stop us from bleeding. First thing that's going to happen is our blood vessels are going to constrict to try and hold on to the blood that we have, okay? Then we're going to see that we are going to have an increase in our extravascular pressure, which is going to compress that injured blood vessel. We're going to see that platelets are going to start to migrate and aggregate over to that site to stop the blood loss. Then we have this intrinsic and extrinsic pathway that are going to work together to form a blood clot. Sometimes patients just develop blood disorders, okay, that affect how they're going to clot, how well their blood clots. Some patients develop some thromboembolic disorders. These are conditions that predispose a person to developing clots and emboli when they shouldn't. Okay, so the body's just developing clots when there's no reason to. Then we can have hemorrhagic disorders, which cause excess bleeding. So the complete opposite of the thromboembolic disorder. So we have 3 different types of anticoagulants. You guys need to, or how 3 types of actions with our anticoagulants. You guys need to understand the classes of these medications. You will need to know this for your exam. You need to understand it and be able to apply it. We have medications that are anticoagulants. Anticoagulants interfere with the clotting cascade and our body's ability to form thrombin. An example of these medications are your warfarin or Coumadin. Antiplatelets, they are going to alter the formation of platelets. So they work differently than anticoagulants. They don't interfere with clotting, they interfere with platelets. Antiplatelet medications are going to be aspirin, clopidogrel. Okay, then we have our thrombolytic drugs, which break down the thrombus that has been formed by stimulating that plasma system. So, for example, if you had a patient who overdosed on aspirin, okay, took too much, what do you think we would do to treat this patient? Not the same thing that we would do for a patient whose blood was too thin because they were taking warfarin. So because it's antiplatelet, It's keeping the body from forming platelets. So if a patient takes too much aspirin, we would give them platelets, okay, to be able to reverse that system. So please read in your book, find outside resources, ChatGPT, whatever you have to do to understand the difference between how these medications are working in the body. Some of our anticoagulants, Pradaxa, Xarelto, Eliquis, these medications do not require any blood testing to look at blood levels. Okay, so obviously if we're not monitoring the blood, it can get too thin and it can cause patients to bleed to death if they sustain injuries. Warfarin, been around for many, 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 many years. We do a lot of ongoing testing when these patients are taking these. However, for some people, especially people that are not able to get out of the house or patients who are not going to be compliant, this might not always be a great medication for them because they have to go into the Coumadin clinic every couple of weeks and make sure that their levels are good so it's not too high and not too low, okay? Too high, they bleed to death. Too low, they get a clot and they can die. Heparin is a medication that we can give that inhibits the conversion of prothrombin to thrombin. And then we can give antithrombin medications, which are used for different hereditary antithrombin conditions. You don't need to know that antithrombin for your exam. The other ones, yes. All right, so how do anticoagulants work? They interfere with that normal cascade of events in the clotting process. How do they work? Very different based upon different medications, okay? Contraindications, we would not give these medications for anyone that could be compromised by an increase in bleeding tendencies. So if you already are at on some type of an anticoagulant or an antiplatelet or something like that, we wouldn't want to give these medications. Or if you already didn't have enough circulating blood in your body. All right, we have to be careful. We're going to be watching these patients for bleeding, okay? Bleeding, bleeding, bleeding. We are worried about them bleeding because we are thinning their blood. Worried about liver function, bone marrow suppression. Sometimes patients can develop a painful erection. If a painful erection lasts for 4 hours, this is a problem. We need them to come to the hospital. Drug-to-drug interactions. Anticoagulants will interfere with heparin and other oral anticoagulants. Some of our salicylates, okay, so you guys need to go back to when we talked about salicylates. There's an increased risk for bleeding with these medications, okay? Need to be very careful. Some of our antibiotics also decrease the effectiveness of our anticoagulants. So if you're on warfarin, we may need to increase your dose temporarily if you are on an antibiotic, okay? Aspirin, ibuprofen, medications like that also thin your blood. So we have to be very careful. We have something called low molecular weight heparin. The medication that we give often in the clinical setting is called Lovenox. You need to know this medication, okay? How does Lovenox work? It inhibits the thrombus and clot formation in the body, okay? So it keeps the body from clotting, okay? That thrombus formation, okay? It does not greatly affect thrombin, clotting, or prothrombin times. Therefore, this is a medication that we don't see a lot of systemic effects with. It blocks something called angiogenesis, which is a process that allows cancer cells to develop new blood vessels. So, low molecular weight heparin, which is Lovenox, is going to be indicated for use in the prevention of clots or emboli after certain surgeries or on bed rest. So if patients have had surgery or they are on bed rest, we're worried about them developing a blood clot. So we're going to give them this medication. This medication does not dissolve clots that they already have. If this patient comes in and they have blood clots in their lower extremities, we are not going to give Lovenox for the treatment of an active blood clot, okay? We call Lovenox low molecular weight heparin, but I don't want you to confuse it with heparin, okay? It's Lovenox. Does not dissolve clots. It prevents the formation of new clots. There is an antidote for this medication. You guys should know that. If we give them too much and thin the blood too much, we can give protamine sulfate. Next class of medications are antiplatelets. These inhibit platelet adhesion and aggregation by blocking the receptor sites, okay? We're worried about patients developing clots, so it reduces the risk of recurrent strokes, TIAs. It reduces death from myocardial infarctions. Sometimes we put patients on this to prevent another MI or any type of an MI from developing, okay? They are also considered anti-inflammatory. They are also have analgesic properties to them and antipyretic effects. So they can reduce pain and inflammation and fever. A good example of an antiplatelet is your aspirin. We have to be careful with anybody that has a bleeding disorder. If they've had any recent surgery, we would not want to give these because we are worried about them starting to bleed again. If they have a closed head injury, we're worried about them bleeding into the brain. We would not give them this medication. Adverse side effects, we know it's going to thin the blood. It's going to prevent it from clotting as well as it normally does. So we're worried about the patient bleeding out. And we would never want to combine it with a medication that causes, that affects the blood clotting. So remember, if a patient overdosed on aspirin or they were bleeding too much and from some type of an antiplatelet, we would have to give them platelets, okay? Because we would want to put platelets into the system, into the body. Some of our thrombolytic agents, this is what we call our TPA or our streptase. So our thromboembolic agents work to break down fibrin threads in a clot to dissolve a formed clot. So this is a class of medications that will dissolve clots. What type of medication does not dissolve a clot? Your low molecular weight heparin, which is your Lovenox. They do not dissolve clots. Thromboembolic agents do. When do we give this? We give this when patients are having a blockage and they have acute MI, they've had a pulmonary embolism that's traveled throughout the body, or if they're having an ischemic stroke, which is a blockage somewhere, okay? These are medications that are injected into the body. When would we not want to give these? Very, very important. We would not want to give if you've had any recent surgery. So big protocols around this. If you've had surgery in the last 3 months and you come in and you're having an ischemic stroke, you cannot get TPA. If you have any active internal bleeding and you come in and you're having a stroke, no TPA, you're not a candidate. If you've had already a CVA within the last 2 months, not a candidate, no TPA. If you have had any type of recent, delivery, if you had an aneurysm, not a candidate. If we had any organ biopsy in the last 2 months, you cannot have it. And if you've had any GI bleeds, you may not have it also. So what are we worried about? Bleeding, hypotension. Sometimes a hypersensitivity, they can develop an anaphylactic reaction, can affect our breathing, facial flushing, and they can develop a rash. These medications are also contraindicated if you are taking an antiplatelet or an anticoagulant, because we know it's going to increase the effectiveness of those medications and the patient's going to bleed too much. What are some of these bleeding disorders that we could see patients have that are treated with clotting factors? So hemophilia, which is a genetic issue that where these patients lack clotting factors that leave them very susceptible to basically excessive bleeding, okay? Liver disease, again, clotting factors and proteins are needed for clotting, but the liver's not making them. And then bone marrow disorder. So platelets are not going to be formed in the enough quantity in the body to be able to be effective. All right, we have our, anti-hemophilic medications. So these replace clotting factors that are genetically missing or the body just doesn't make enough of. We would give them to prevent blood loss from injury or surgery and to treat, just your regular bleeding disorders. We have to be careful with pregnant people, increased risk associated with the use of blood products. Patients might develop headache, flushing, fever, chills, nausea, vomiting, stinging and itching at the site. We have our systemic hemostatic agents, okay? These are going to stop the plasminogen clot dissolving mechanism in the body that occurs naturally, okay? We're going to use these medications to prevent or treat excessive bleeding in hyperfibrinolytic states. We would not want to use if these patients have an allergy. We have to be careful with patients that have cardiac disease. Adverse effects would be excessive clotting, right? We're always thinking that we're going to cause the opposite problem. We wanted to fix something, but now we've overfixed it. All right, it's going to affect our central nervous system. So we're worried about hallucinations, drowsiness, dizziness, weakness, cardiac arrhythmias. All right, blood components. How do we treat anemia? Sometimes we give blood. So we can give, when we think about when we actually give, something to treat anemia, we want to think first about what are the components in our blood. So what makes up our blood? So we have plasma. So our plasma is really just that liquid part of our blood that holds all the proteins that we need to have a good immune response and to help our blood clot. Then we have some more elements that are in our blood. We call these our formed elements. We have our white blood cells, which are also referred to as our leukocytes. We know our white blood cells are definitely part of our immune system. Then we have our erythrocytes, which are our red blood cells, which carry oxygen to the tissues and remove carbon dioxide. So this is the process of erythropoiesis in the body. I would have an understanding of what that process is for your exam. So what type of anemias can we see present? Well, we have something called megablastic anemia, which is where these patients do not make enough folic acid or B12. So because they're lacking the folic acid or B12, we're not able to make a very good functioning, healthy red blood cell because we need these two things to make a very good red blood cell. We see patients that develop iron deficiency anemia. So this is when we have a negative iron balance in the body. And this can occur for a couple different reasons. Sometimes we just don't take in enough iron. We don't get it in our diet. Definitely people at risk would be those menstruating women who lose red blood cells every month. Definitely pregnant and nursing women because they have more of a demand in their body now for iron. Definitely see this in our rapidly growing adolescent patients because they don't usually have a great diet. And then people who are suffering from any type of bleeding in the body, particularly GI bleeds. Pernicious anemia is something that develops in patients because inside of our mucus, our mucosa layer, I can't talk today. Inside of our mucosa layer, inside of our belly, we have in that gastric mucosa, the body makes intrinsic factor and vitamin B12. So that cannot be absorbed. Okay, so they develop anemia. All right, so this is the process of erythropoiesis, and erythropoiesis is going to control the rate of blood cell production. So if we do not this is going to be directly related, to our oxygen use in our tissues. So for some reason, just think that our oxygen decreases in a patient, variety of different reasons. They could be bleeding, they could have a respiratory issue. Well, when the body senses that we don't have enough oxygen, it's going to stimulate erythropoietin to be released, which is then going to say, hey, stem cells, I need you to start making red blood cells. Those red blood cells are going to then be formed. We know if we have more red blood cells, they can carry more oxygen. If we have more oxygen, we're going to increase the oxygen in our body. Okay. And then the kidneys are going to say, oh, okay, we have enough oxygen now. We can stop secreting erythropoietin because we have fixed the system. So this is that compensatory mechanism in the body. So we also have medications. So remember we said that this happens in the kidneys. So some people, diabetics, people who don't treat their blood pressure. We see these very commonly have issues with their kidneys. So we have to make this process happen for them because they will be anemic. Okay. So we can give them some erythropoietins. So we can give epoetin, which is Epogen. Okay. This will treat anemia associated with renal failure, patients that have AIDS. It decreases the amount of blood transfusions they're going to need. You do need to know that medication for your exam. And you need to know erythropoiesis and how it happens, where it happens. We can also give oral iron preparations. So some of the most common ones that you will see, ferrous fumarate, ferrous gluconate, ferrous sulfate, and then ferritab or slow Fe. When would we have to give these oral preparations? Well, sometimes for folate issues and B12 deficiencies. So why would a patient develop folate deficiencies? Well, sometimes just because the body doesn't make enough, okay? Just doesn't make enough for some reason. We might have absorption issues in our small intestine. Think of our patients that have had gastric bypass. Drugs that cause folate deficiencies, different medications cause this, or secondary to malnutrition from alcoholism. We've talked a lot about this semester. Patients with B12 deficiencies, either poor diet or because the body doesn't make enough, or they may have a lack of that intrinsic factor in the stomach. Big population of patients, gastric bypass patients. And that is it for week 8 and our perfusion.